Welcome everyone to the Understanding School-Based Mental Health and Medicaid webinar series. This 5-part series is designed to build a shared foundation of understanding how Medicaid supports mental health services in both school-based and community-based settings across the state of Illinois. The vision of this series is to support the provision of mental health services to students within school settings to reach all youth, and especially those that may be most vulnerable that cannot access services otherwise. My name is Matt Buckman. I'm a licensed clinical psychologist, duly credentialed as a school psychologist, and also the executive director of the Stress and Trauma Treatment Center. I will be guiding you through today's content and this 5-part series. This webinar was developed with support from the U.S. Department of Education's School-Based Mental Health Services Grant awarded to West 40 Intermediate Service Center No. 2 in partnership with the Stress and Trauma Treatment Center. This material is provided for educational purposes as a broad overview. It does not replace the official guidance from HHS, CMS, or the Illinois Department of Healthcare and Family Services. Regulations and compliance requirements can change, and participants should always consult authoritative sources. This is a 5-part series. This series progresses from foundational Medicaid concepts to increasingly more specific applications. Starting with a foundational understanding of Medicaid allows us to dive deeper into the school-based reimbursement system, community mental health services system and reimbursement for this, and specialized care coordination service organization and pathways programs. The final part of this series will be a discussion of ideas for action, which will build on the previous content and identify concrete steps or strategies to leverage funding to increase access to mental health services for students. Part 5, Ideas for Action, Increasing Mental Health Services for Students in Illinois. During this part of the series, we will focus on Medicaid outreach and looking at staff pooling, cost reporting, service provision, and community partnership ideas to be able to increase and expand mental health services in schools and for our students that have the highest need. Utilizing the Healthy Schools Campaign mapping system, looking from the start to the finish, we're going to break down some opportunities for what you can do as a district to be able to expand mental health services and maximize reimbursement through Medicaid. First and foremost, obtaining consent for all students. This is something that all of our districts can get in the routine of doing early on in early school enrollment, because one consent lasts a lifetime for that student. And then as students transfer into our district, we can put that as one of our areas that we are collecting this information at the onset of services or the onset of schooling for that youth. ISB has that parental notice. That it's an example that's available there, but you can use your own as well. You can also, what can you do? You can provide outreach to help families enroll in Medicaid. We want to be able to have more and more students enrolled in Medicaid. This allows them to get primary care services for some of their dental services, although hard to find, can be reimbursable by Medicaid. We can see if there's a car accident, if they go to the emergency department, if any type of surgeries that were unexpected or any surgeries that are needed, that will be reimbursed by Medicaid versus the huge burden of healthcare costs that can financially break and bankrupt a family. We can conduct regular education, awareness activities, review eligibility, help determine eligibility, and help apply for Medicaid. That is a preferred and higher reimbursement rate. But as we're doing this, we're providing a greater good than just getting reimbursement through this service, but helping individuals that may be eligible be able to get access to that. The application for benefit eligibility website that is provided by HFS in the state of Illinois. That website is very valuable. A person can go there, they can check if they should apply, so they can just put in their information, to be able to test it out without putting in any identifying information. So sometimes you can know what a family's income is and how many individuals live in that family, and you can submit this through a process of just checking eligibility without putting in their actual demographic or any protected health information or protected information from the educational system. And so ABE can be utilized. And then if families want to apply for benefits, you can support families as they're going through this application process. Again, this is a Medicaid reimbursable activity, but it's also an important activity to save families money and help youth who are eligible for services continue to get Medicaid. In addition to that, there's an ABE application guide, but you also can go to your local DHS office. And so you can look up in the office locator at the Illinois Department of Human Services to be able to find where is a local office so that my families can go there, or we can talk to them over the phone. Like with many different eligibility types of systems, whether it's state or local, it may be hard to be able to get in. So one of the strategies oftentimes people use is calling first thing as soon as their office opens, before we find ourselves backlogged with lots of phone calls within any of these departments in the state of Illinois. What many people are not aware of is the federal poverty guidelines. So here's the guidelines for annual. We also will provide that for monthly. But when we're looking at annual guidelines and you're looking at the family size, depending on the family size, the poverty level can actually be quite a bit of a household income, more than what many people will know about. And when we're getting to youth and we're looking at our expanded population through all kids that's available through the state of Illinois, that's up to 318% of the federal poverty level. So if I'm a family of 5, then my family can make $112,950, and my child might still be eligible for Medicaid. Now, I might not be eligible for that, but my child may be eligible. And even if I have commercial insurance that's available to me, and my child is covered through my commercial insurance, they can still have Medicaid as a secondary insurer. And in doing so, that can offset a lot of the healthcare costs. And I'll talk a little bit more about out-of-pocket costs later on. That can offset those costs. And not all commercial insurances are equal. There are some commercial insurances that have very high deductibles or co-insurance or very high copays that actually make it where families do not utilize services or preventative care or early identification type of services. And for those individuals, to get them on Medicaid may actually mean they will utilize healthcare services that can intervene early so that more costly, more significant health issues and challenges don't occur later on that could have been prevented or intervened early on with minimal effort. So what can we do? Outreach to help families be able to enroll in Medicaid. But once they're enrolled in Medicaid, there's also an important activity that is helping families stay enrolled, is that there's a redetermination that happens on a yearly basis. And they don't do it all at the same time, but it's a certain time of the year for certain letters of the alphabet for last name and things like that. And so what's going to happen is they're going to get a redetermination letter. It could be their income hasn't changed, their household size hasn't changed, and they are 100% eligible for that. But if they had moved, perhaps, and they didn't update their mailing address, which happens all the time in the Medicaid system, that family didn't update the mailing address, then that redetermination letter that says call here or submit online your updated information, if they don't get that letter and they don't do that process, they will be dropped from Medicaid. There's some question of whether or not open enrollment will be available, or if it's only during open enrollment period that someone will be able to re-enroll in Medicaid. But they could be dropped. And then it's as simple as going online and saying nothing has changed or here's my information, and it be that quick. And so if we help our families by encouraging them that if we know there's an updated or a change in address, that we encourage them and help them update HFS's system through that renewal request. So that way they're getting all the mailing information that they would be eligible for, which sometimes your managed care organization will change. Sometimes, as I talked about with CCSOs and Pathways for Success, that letter that says you're eligible for it, that will go to whatever address is in the HFS system. And so we want to update that system. We can go online, we can help families do it really quickly, but helping them keep an updated address will help them continue to be eligible and to get the notifications of any important information that HFS may be putting out. Now, if families do lose coverage, it's important that we help families reapply for that coverage. Now, there's a window of time when you lose health insurance that it's a qualifying event, that they can do this. They can apply online. But outside of that time period, I'm not sure if the new legislation coming out of the federal government is going to allow outside of that time frame to be able to apply for Medicaid coverage. So it's important that, one, we don't allow them to go outside that window if it does exist. And two, if something were to happen to the youth, that whatever claims they might have, whatever services they might have, would not be covered by Medicaid. That includes the school health services that are being provided. So those services would not end up being reimbursed through administrative claiming or through direct service interim payments or cost reporting or cost settlement. That would affect the reimbursement that happens to the school. And if something were to happen to the youth, they do not have coverage at that particular point. So we don't want youth to be able to fall without coverage. If we know they don't have it, help them. This is a Medicaid reimbursable service. Help them obtain that coverage again. It can be some question of who's responsible for that. Many times, families and youth, they don't even know they don't have coverage until it's too late. If we find that we're able to help a youth or a family is able to get Medicaid coverage, it will go back up to 60 days to cover claims that had already happened. So if they were participating in school-based health services and we got them coverage, but maybe we didn't know it for 30, 45 days, when we submit that application, it'll go back 60 days from that application if it's approved. And so as long as, we don't have to be perfect with that, but as long as we are monitoring and keeping up with it and helping families keep up with this, their coverage for claims will continue without any real gaps, as long as we can do that within 60 days. The next piece is to identify the eligible providers. This is a very important part when we're looking at our staff pooling and we're deciding who's in cost pool 1, who's in cost pool 2, who's in cost pool 3. As an example, with cost pool 3, our paraprofessionals, if they are not included in our cost reporting, then we're not going to be able to get reimbursement for those paraprofessionals that very much could receive reimbursement. When we're looking at our new expanded through the SPA, we're looking at ISB certified counselors now are eligible. Several clinical professional mental health providers can also be employed by the school, and we can utilize Medicaid reimbursement. And that can be employed through a contract or be direct payroll employees of the school district. And we can see reimbursement for those providers. Now, with social workers, we've always had the ability to use medical social workers versus educational social workers. But many times we would misclassify those providers as educational social workers instead of medical social workers. So anyone that's providing direct services should be included in the staff pool as a direct service provider. Even though I'm in a direct service provider, I can still do the administrative thing. So I can still get administrative or Medicaid administrative claiming. I can still do that for outreach and other things in addition to the direct service. So there's multiple ways of getting Medicaid reimbursement if we have the direct service providers in the right cost pool or in the right staff pool, I mean. Here I'm noting that there's the difference is if someone provides direct services, if I'm a school counselor, I could be considered a school counselor in this respect or an ISB licensed professional educator licensed counselor. Most school counselors are that, right? I think maybe all are, but it's a matter of how do we classify the role. And so, even if I identify as a school counselor, doesn't mean I'm not going to be put in as an ISB licensed counselor, because that is more not necessarily about the right definition or about what the associations believe or about what I identify as. It's about if I provide any services directly to students, I am an ISB licensed counselor. Same thing with educational versus medical social worker. Medical probably sounds more complex or complicated. It's the exact same degree, the exact same license. It's just a matter of, do I provide direct services? So it would be rare for me to put someone, a school counselor or a school social worker, in cost pool 2. Almost always am I going to put them in cost pool 1. Well, with the exception of if they're 100% funded by federal funds. So that includes, like, if we use IDEA funds or certain types of federal grants or federal dollars, um, if we're using them to fund our counselors or social workers, if that's the only option, I get it. We don't want to turn money away. We want to be able to utilize those funds. Sometimes there are things that are not Medicaid eligible but are eligible to be funded by IDEA. And so, as an example, one expert with the School Medicaid Consulting LLC recommends that you use your paraprofessionals and you put them in IDEA versus your direct service personnel, because your school health aides or paraprofessionals in cost pool 3 actually get a lower federal percentage reimbursement. And so, when you could use that strategy, or if there are some things that aren't included, cannot be included in Medicaid cost reporting, then put them in the federal, in a federal grant. And so finding ways to do that can be an effective strategy to be able to help you maximize reimbursement. Documenting our medical necessity, that can be a very easy process, but remember, that's not something you turn in, it's something you just keep in your record. What's really important for us is making sure we're providing the documentation, but we're submitting our financial reports so that we can get our claims reimbursed through HFS. Those financial reports are so essential to the success of reimbursement through Medicaid that it may be one of the most important aspects of it, to make sure, one, we have all of our people that are in our staff pools, that all of their information is included there, plus our indirect. And in those cost reports, we're going to put our interim payments and some of that's there. But those reports will determine the reimbursement rate for interim claims and the ultimate reimbursement we're going to get 1.5, 2 years after the school year. In that time frame, when we get that reimbursement in the cost settlement model, that's all based on the amount of money that is eligible cost. So it's all based on that. So the larger the pool of money and the more people that are in that, given they are doing some of these activities of administrative, Medicaid reimbursable administrative activities or direct service activities that are Medicaid eligible, given they're doing those services, that is going to give you the maximum amount of reimbursement at the end of the year. When we're looking at fee for service, I mentioned this before, but I want to mention it again. Remember that the rates may be lower because they're based on 2020 rates. So if you're not a special education cooperative or you're not a district that has been providing special education services um, before 2020 and multiple years before, then understand that your rates for your interim payments may actually be pretty low compared to what your actual cost settlement amount will be a year and a half or 2 years from now for services that are being provided at this. The random moment time study process is essential to maximizing Medicaid reimbursement within school health services. When we're looking at the random moment time study, it's important that all of our providers are ready and all of our staff are ready, because it doesn't matter if you're in staff pool 1, 2, or 3, whether it's administrative primarily, whether it's other direct service, or if it's direct service providers, it will not matter. Everyone will get a random moment time study or multiple throughout the year, and it's important that they complete those accurately and in a timely basis. Now, there are some things you can control and some things you can't. I want to talk about some of the things we can control. So when we're looking at our time study code indicators, we're looking at how can we maximize reimbursement? What are the activities that are reimbursable versus activities that aren't? And let me point out a few of those activities that I think will make a difference in whether or not you get more Medicaid reimbursement versus less. To do this, we're going to use that provider example I used earlier on in the series, where we're looking at a provider, a school-based mental health provider that in total costs $110,000 for that provider alone. But understand, rarely are we looking at one provider in our cost reporting. Most of the time, it's going to be multiple providers, and we're going to be multiplying these numbers over time. First, we can participate and create training. We know that if we're training on Medicaid and Medicaid reimbursable activities, that is an administrative claiming activity that is reimbursable, but train our staff to adjust their scope of work to focus on Medicaid reimbursable activities. So I oftentimes refer to this as top of the license. And so I won't have a licensed social worker or a licensed psychologist or a licensed counselor and have them do things that my administrative staff or my support staff can do. Instead, I have them do top of the license work that requires their specialized training. And by doing so, oftentimes that will mean we're going to see more Medicaid reimbursable activities that are happening. We also can look at our MAC, Medicaid Administrative Claiming, and look at how our meetings and our trainings and our planning processes and our leadership and our team meetings are happening, and see if we can focus those meetings or even educate those participants in those meetings to understand that we are focusing on Medicaid and Medicaid approved service providers and Medicaid approved services. And so many times when we're looking at quality mental health services or other health services, those are going to be the ones that are Medicaid approved. And so if those random moment times end up hitting during those meetings, our staff will hopefully know that if they're in one of our staff pools, that those individuals are educated to know that those meetings that we're having, those trainings that we are integrating and specifically focusing on Medicaid approved services and Medicaid population when we're doing those things. Now, many times what I will do is that since Medicaid, typically the Medicaid population is a more at-risk population than my others, many times we may focus that for the entire meeting, and knowing that it still applies to the entire school population as far as what we're doing, but we are instead focusing and targeting the higher risk population or subpopulation of my student body. Another thing you can do, educate or translate job activities to Medicaid reimbursable language. So when we looked at those activity codes, how do we incorporate that into job descriptions or job activities that are practically the same, but instead we want to make sure that our staff are understanding those activities in terms that will match the random moment time study or even the direct service fee for service claims and interim billing that we might end up doing. So that way we can translate this and understand that when we're doing these random moment time studies, that we are doing Medicaid reimbursable activities using those terms and that terminology. Using our provider with $110,000 is the total cost for that one provider, we can look at the quarterly PCG Medicaid administrative cost claiming reimbursement for non-outreach. And in this, I've broken that down to look at what would be that hourly rate for an individual using an example of 880 hours in the school year at 10%. So 10% of their role would equal 88 hours, and that would translate to about $36.95 an hour is what the reimbursement rate would be. Although, understand that's not a cost settlement model is not a fee for service model. So it's not intended to be broken down this way necessarily. And I want to be able to reinforce that a point that I'm going to make later on related to reimbursement rates. But as we're looking at this, non-outreach is that level. But then when we start looking at outreach, we're looking at the highest approved rate that's there because it doesn't necessarily slice or reduce down for the Medicaid enrollment rate. And so we're not reducing Medicaid enrollment rate when we're looking at helping individuals, giving education, helping individuals know if they're eligible for Medicaid and enrolling in Medicaid in those eligibility determinations and helping people become Medicaid recipients. So when we're looking at that rate, now we're looking at maybe it's 5% of the activities that a provider might do. Let's say we're looking at a school-based mental health, so we're a direct service provider. That translates to about $62.50 per hour when we're looking at that. And that's because we're getting the 100% total Medicaid rate here. And that's the difference. That's a significant difference in how much reimbursement will occur. Now, you could double this, you could triple this, right? It could be 10%, it could be 15%, it could be 20%. I'm not sure how much the percentage can be for your staff pool. So it won't be that individual when you get that rate. It'll be the district's direct medical percentage of how much time is spent on Medicaid outreach. And so the whole district's in it together, just like when we look at our cost settlement later on, as an estate, we're all in this together, and we all share that. Then we're looking at time study codes for direct service providers, and they're still going to have the proportional Medicaid codes, but some of those activities are providing services. They have to match to the plan of care or an IEP or some type of medical 504 plan or medical plan that has been developed. But as we're providing those services, we can provide them to IEP students or students with IEPs, and we can provide them to students without IEPs through the free care plan. I want to point out, though, the differences between an IEP cost settlement and a free care cost settlement. So let's go down the line here. We're looking at a provider that costs total $110,000 a year. The IEP direct medical percentage, again, that is a statewide average, is 38.16%. I don't get to use my individual district average, nor do I get to use the individual provider average. I have to use the statewide average. We are in it together when we get to these cost settlement models for direct medical percentages. Now we look at the IEP ratio with Medicaid. We're almost always going to see a higher percentage of students with IEPs that are on Medicaid than our general population. So that percentage is oftentimes going to be higher. And then we're coming back to our state federal medical assistance percentage or FMAP, getting us our total for that particular provider, $15,496,000 multiply that by 10 providers, that grows significantly. But also we have an hourly rate down here that was calculated, again, using 880 hours per school year. And the calculated rate was $46.15 per hour. When we look at the free care cost settlement, a significant factor here is the direct medical percentage. So remember, the direct medical percentage is the average across the state of what percentage of time is reported providing this particular service for a Medicaid reimbursable student and Medicaid reimbursable service. And so when we're looking at this percentage, the average for the state in this particular year that we're looking at is 4.74%. Now that can increase. These things will change over time, but that percentage is always going to be keeping the amount of reimbursement that you can get at a district at a minimum. Then we look at the Medicaid ratio. This Medicaid ratio, almost always, the Medicaid enrollment ratio is almost always lower than the IEP ratio. So we're also looking at a reduced ratio of that amount of money. FMAP is the same. And the difference is now we're looking at about 4.74% or 5%, and that's $1,583. But again, multiply that by 10 providers for free care, we're seeing $15,000 in reimbursement to the district through the cost settlement model or the interim direct payments, which can happen as well. But that's around a $37.97 per hour reimbursement. I will say that's an hourly rate, but that is not an unlimited hourly rate. That's going to be limited to the direct medical percentage. So when the overall state for everybody in the staff pools that are across the state, if we're limited to about 5% of everybody's time in providing free care services, then that's always going to limit this. Now, we have only experienced reimbursement for year one and year two. And so those reimbursements for 2022 and 2023 that happened, the reimbursement came in 2024 and 2025. However, keep in mind that the process for approval took multiple years for our state plan amendment. So many of our districts have not been prepared for this and are just now learning the ins and outs of this process. So we may see the direct medical percentage increase over time for free care or the general education students. But overall, let's look at our provider that costs $110,000. Let's put it all together for Medicaid administrative claiming. That was standard administrative claiming. That was about 10% of their time, got $3,251. MAC outreach was 5% of their time, got $2,750. But again, if I could increase that across my staff pools, I absolutely would. That's going to be a very higher reimbursement rate. IEP direct services around 38%. That's $15,496. Free direct care or general education students with a plan of care that are on Medicaid is around $1,583. But overall, for my $110,000 staff member, I'm able to reimburse $23,081. Some of those may be the administrative claiming that is interim or quarterly coming from PCG that comes from the comptroller's office. And some of that may be interim direct service claims that come from my vendor for fee for service. And then ultimately, a lot of that will end up coming 1.5 to 2 years later in my cost settlement. And that's when the money will actually come for reimbursement for the provision of these services. A reminder about the cost settlement system that we're going to get total allowable cost, subtract our interim payments, and that's going to give us our cost settlement amount. And so all of our salary and benefits and all of an indirect rate that goes into cost reporting, that gives us our total allowable cost. We get interim payments along the way, but even if we forget even if our providers don't do the paperwork and don't submit within the fee-for-service system, specifically the fee-for-service system, that's okay. We'll still get the cost settlement dollars. Now, when you get to Medicaid administrative claim dollars, that may not be the case, right? That is important that we are doing the random moment time studies. If we don't have the random moment time studies, there's no cost settlement. If we don't have 85% of those, there's no cost settlement that ends up occurring. So it's very important that we do the random moment time studies. But if we forget to do the vendor fee for service, the cost settlement will still flush out. However, cash flow is a very important part of running any organization, including a school district. And so we could find ourselves strapped for cash, even though we know the money will be coming in a year and a half or 2 years if we don't have the interim payments that could be there. So what's another thing we can do? We can focus on providing services to students with IEPs. Even district-employed school-based mental health professionals can provide services within the IEP, and this will give a better Medicaid reimbursement than other systems. So one of them is the proportional Medicaid. When we're looking at proportional Medicaid for IEP enrollment rate, we're always going to see a higher percentage of students with Medicaid that have IEPs than the overall student population. This overall student population is what we use for free care and Medicaid administrative claiming. When we look at the IEP cost settlement formula, you're looking at 38.16%. And in my example here, which will be specific to the district, an IEP ratio of 71.85%. But when you look at free care in your gen ed, you're looking at almost about 5% in direct medical percentage and a lower 59% in the Medicaid ratio. So by providing services and ensuring that services are being provided by all of your direct service provider staff pool, by providing those services to students with IEPs, you are increasing your Medicaid reimbursement significantly through this process. Now, there are multiple ways of doing this. Many school districts might have a special education cooperative as an example. One is the special education cooperative can be that provider. So as we're expanding mental health professionals, we're expanding providers, we can expand within the cooperative. Or if there is a cooperative and the district doesn't necessarily provide all special education services, student IEP goals can split the minutes between the two, with some minutes being provided by the district and some minutes being provided by the special education cooperative. And there's nothing that limits that other than the collaboration and agreement between the district and the special education cooperative. And so student IEP goals can be split. And that's one way to be able to increase district reimbursement through Medicaid if the district isn't the primary provider for special education services. Another way is when the district gets funding and grants and certain things that might be there, they can pass the funding over to the special education cooperative through a mental health professional role, and that special education cooperative can in turn give a higher allocation of time to the district. So many special education cooperatives might provide a certain fee split up, administrative cost split up across all districts, and then also then an allocation of time breakdown for the specific district's use of special education staff and services. Now, in that, the trade-off for that is the district gives funding, the district gets the allocated time that they're purchasing through creating this expanded role. The special education cooperative gets additional staff members and mental health services. But another trade-off is, since the special education cooperative will, one, get higher interim rates because they've been doing this, the provision of school health services much longer and much more frequently in 2020 when the rates were set. The interim payments will be higher. Now, the cost settlement payments will ultimately be the same when you come down to 1.5 to 2 years later. But the special education cooperative can reduce the district's bill or cost by the Medicaid administrative claiming dollars that are collected through the providers that are there at the special education cooperative, the IEP cost settlement dollars, and the free care cost settlement dollars. So ultimately, when money's given to the special education cooperative, it those providers will produce a significantly or a significant amount of Medicaid reimbursement that then can reduce future cost to the district in that settlement that ends up occurring between districts and special education cooperatives. I'll reinforce this again, very essential that finance offices are completing and certifying quarterly cost reports, and that all the providers in the cost pool, everybody that's being included in any of the staffing that is included in that the indirect rate, that is the negotiated rate, ends up in there, that all the appropriate or potential expenses, because the higher the cost, the amount of cost report that is accurate, the higher amount of that, the more Medicaid reimbursement will occur through the cost settlement model. Missing cost reports may result in returning interim payments that might have been received, or might actually disqualify from getting any cost settlement funding, Medicaid reimbursement for those quarters. Now, whenever it comes to experts in the field, there's lots of different, there's consultants out there. I've used some in the development of this particular training, but there's also vendors. When you look at your fee-for-service vendors, they have lots of resources. If you go into PCG, Public Consulting Group, that's where you're going to put in your staff pools, that's where you're going to do your cost reporting. It's important that leaders in the district, not just financial managers and CFOs, are in the PCG system, because you can learn more about how the system functions and be able to influence what you can control. And some things you can't in this situation. And you just get the Medicaid reimbursement dollars that you can get, and you can't control the variables. But there are some variables that you can control. And that's what I want to be able to highlight in this part 5 of the series. We also can find ourselves not able to build the capacity within the school district to address the needs of our students. Sometimes we can enlist a community partner as something to do. They could either hire a staff until they are certified, or indefinitely, and hire staff for our specific district. Sometimes we can come with our own staff member that we're looking for. We can make referrals for the youth that need it and participate in those coordination of services. We can influence community agencies to do more of their part, or follow through with maybe what's expected or what we need for our particular students. And we may be able to influence them and influence a system of care in ways that we're all filling gaps for the services that are important for our families. Some of the guidelines or strategies is to establish a communication mechanism. Maybe it's email, conference calls, team meetings, to ensure that leadership in both the community partner organization and in the school are collaborating and understanding each other's point of view and perspective. We might create memorandums of understanding or some type of agreement that details the terms of who does what and when and where, and who's paying for it, and how will services be provided, so that there are clear expectations for both the community partner and our district. This may allow us to develop a larger continuum of care with more tiers of supports, and especially more supports for our highest need youth that are within our school, that oftentimes take the majority of our mental health service staff and our other, even our disciplinary system many times takes a lot of the resources and capacity of our district. I want to share some of the rates that are available throughout our community partnership agencies. So we've got to see some sample rates, but keep in mind that a cost settlement model doesn't quite translate into the same type of rate system. But let's look at federally qualified health centers and the rates that might be available there. For this particular system, or for those systems across the state, we're looking at about $84 per hour in a fee-for-service reimbursement system, although FQHCs and rural health clinics oftentimes have a little more of a cost settlement and cost reporting system that determines some of these rates. When we're looking at rural health clinics, we're looking at approximately $80 per hour as a reimbursement rate. Knowing these rates might be able to help districts understand more of the funding mechanisms and the potential for reimbursement for some of the service providers that could be a partner or a collaborator in some of those services. If we have a school-based health center, the rate is around $91.58, so around $91 an hour is what the reimbursement rate will be for what's considered a 90837, which is a CPT code specific to providing therapy or counseling services within a school-based health center. So what can we do? We can collaborate with our community partners. Sometimes we're going to hire known and effective providers or professionals or paraprofessionals. We know they're good. Maybe they're in their internship. Maybe they're in training at this particular point. Maybe their personality, their lived experience, their experience and as a paraprofessional or a sub within our district makes them a perfect candidate. There are people that are trained and have degrees to show for it that are very effective. And there are people that are trained and have degrees to show for it that are not very effective. And there are people that are just natural interventionists that change the lives of our kids and promote mental health services that will not be a Medicaid reimbursable person or provider within a school district because of the eligibility criteria, but could be for some other type of entity that can reimburse for Medicaid. So if we came to a community partner, we may be able to encourage them to employ this provider, or we might be able to enlist them as a paraprofessional within our district that could get some Medicaid reimbursement, but at a different rate oftentimes. Some of the key staff for community mental health centers and behavioral health clinics, those provider types, those entities can hire individuals that have less credential, but may be naturally effective or through their lived experience be just as effective as someone with more credential or more traditional education. I wouldn't do this with everyone, but there can be some individuals that we know of in our district that could be highly effective if we want to be able to have more and more of their time on a permanent basis, that we may be able to enlist a community partner to be able to employ that individual and get Medicaid dollars to sustain that position within our district. So when we're looking at community mental health centers and behavioral health clinics, the rate for reimbursement in those is about $139 per hour for the reimbursement for a master's level provider. So when you get to, you're looking at a rehabilitation services associate, someone that has kind of in-house training only, maybe someone peer provider with lived experience, we're looking at that rate will be different. But for a master's level provider, this is what the rate would be for those services. I also want to point out the difference between on-site and off-site. So with community mental health centers and behavioral health clinics, there's actually a differential rate that when the services are being provided in a school setting, in a home setting, in a community setting, there is a higher reimbursement rate that is available to them. And that's about $12.64 per hour increase for a master's level provider or in this system, they're referred to as QMHPs or qualified mental health professionals. So there's a differential rate that could be utilized as an incentive to get providers or get an organization to collaborate, integrate within your school district. A couple of additional points that I want to make related to the strengths and or cost and benefit of having a school-based provider versus a community-based provider. When we look at school-based health services, those services and Medicaid is considered a payer of first resort. And that's unique in the Medicaid system because in community-based providers and community-based systems, Medicaid is a payer of last resort. So those providers have to implement or utilize commercial insurance as the payer of first resort. And then Medicaid can come in as a secondary payer and can even cover out-of-pocket costs from commercial insurance. But it is important that if you submit to Medicaid for reimbursement as a community-based provider and they have commercial insurance, that claim will always be rejected until there's a submission to the commercial insurance and a estimate of benefit or EOB, and then that can be attached to a secondary claim to Medicaid. And so Medicaid cannot reimburse as the primary payer. The system won't allow it to be that, and by law, it keeps it from being the payer of first resort. With out-of-pocket cost, it's important to know kind of how these things interact with each other. So when we're looking at commercial insurance, that has to be the payer of first resort. For community-based providers, it's important to note that there are three types of out-of-pocket cost for commercial insurance. There are deductibles, there's copays or copayments, and there's coinsurance. When we're looking at out-of-pocket maximums, oftentimes what counts are those three things, but not monthly premiums or out-of-network services or non-covered services in the plan limits. And so out-of-pocket maximums are oftentimes something that can be reached utilizing Medicaid reimbursement as an option to be able to cover those out-of-pocket costs. So when we're looking at copays versus coinsurance, coinsurance is like percentage. So it might be like 20% of it is covered by the individual and 80% is covered by the insurance company. And then sometimes there's copays as well on top of that. And sometimes it's two different systems based on every commercial insurance plan being different and having their own way of being able to do this. And a copay is every time a school-based health service or every time there's a mental health service that's provided by a community partner in the school, there's a copay that must be assessed for individuals during that time. It's important to note that that is not an option for the organization to be able to implement those copays or not implement them. They are required options or required assessments that have to be there. When we're looking at Medicaid as a secondary payer source for commercial insurance, many times what can happen is my copay. So I might have a copay that, let's say, a community partner is coming into my district and they're providing a service, and there's a $20 copay for that service. That community partner will bill their commercial insurance first, and then it'll say there's a copay of $20 that's required. They will be able to submit that copay, coinsurance, or deductible amount to Medicaid that then will cover that as a secondary payer source. This helps individuals meet their out-of-pocket expense or maximum for the year. This helps meet their deductible for the year as well. So sometimes someone might have really good commercial insurance or have commercial insurance, but maybe there are additional costs that actually become a burden or a barrier for their child to receive mental health services. So having or helping those individuals consider their eligibility and consider that they might actually qualify for all kids. And there's a lot of families out there that do qualify that don't realize they qualify or think because they have commercial insurance that they can't have Medicaid as well. Those families could benefit significantly by covering sometimes a very high deductible, covering copay cost and covering coinsurance cost that would basically remove all out-of-pocket expense for families to participate in mental health services in the school through community partners, but also mental health services in outpatient settings, perhaps other types of services, healthcare services, and dental services that this Medicaid as a secondary payer source can be a significant resource to families that help them get access to services. Some ideas: if a district decides they want to engage a community partner, oftentimes it does seem like there would be community partners that would line up for access to a population of Medicaid eligible students. What I find is that there's such a supply and demand issue that there's a low supply of mental health providers and effective mental health providers in our communities and a high demand for those services, is that we would have to make sure we are, one, engaging the right providers that oftentimes are not looking for opportunities like this or not seeking out more because they have all the referrals and all the clients that they could possibly serve. So to engage the highly effective, kind of I don't know if you ever know that expression of if you want something done, you ask a busy person. And so the same thing is true when you get to these highly effective organizations, is that we may have to do something to help engage them into our partnership. Some districts will use a small contract to perhaps phasing out over 6 months that can cover the onboarding costs that may be costs that the organization may incur that would not be reimbursable by Medicaid. And so it may be a 6-month kind of rolling out, and then looking at within 6 months or whatever time frame that was agreed upon, sustainability through Medicaid reimbursement would be the goal for that. And hopefully a multi-year partnership that allows the provision of service without turnover for that particular mental health provider that would be coming from that community partner organization. The other is to have referrals and create a culture of collaboration and prioritization of access to services. And so that the leadership team within the district and within the school and the school staff, that there is a culture and there is a value to accessing more mental health services or perhaps other health services, but I want to focus on mental health services for this 5-part series. And so prioritizing that so that when it comes to barriers or challenges or conflicts and scheduling, that there would be a prioritization towards the mental health services happening during the school day and getting access to mental health services that many times outside of school systems, many times students may not get access or may not be able to utilize those services, given the barriers that might exist in the family or in the community. Another way is to provide dedicated space and the resources that are needed to provide those services, such as access to Wi-Fi, access to a copy machine and printer, if possible, access to the building, some kind of access card, even if it has restrictions on certain times that it can work, but that a person doesn't have to be let in or let out, and starts to become more of an integrated member of the school team. Access or on the list for staff emails or text communications. So if there's certain things going on that we're notifying all staff, that those individuals also get included and feel included in that process. I would also recommend that there be flexibility around the service model, mainly because what we may oftentimes know is the IEP service model. And that service model, if we cannot get enough Medicaid reimbursement, as an example, to create an expansion within the district, we have to rely on a different service model that does get enough Medicaid to be able to create an expansion and provide more services. And so it will look different than the IEP service model. By design, it's supposed to, and it has to meet the community Medicaid reimbursement service model so that then that can be sustainable. And we don't provide short-term services that then get pulled out of communities, but instead they become long-term services and supports for our students, our families, and our community. We might have a data sharing agreement where we're able to share information back and forth. Maybe even I've even used consent for services that have releases of information built in that are a partnership between the district and the community organization. And in doing so, some districts even offer access to the student database, and so that attendance records and grades and things like that can all be accessible, and reports can be entered into that by the mental health provider from a community partner organization. But similar to IEP services, providers can only provide services that are specific within the treatment plan or service plan or plan of care. When you're looking at community partners, does have to tie back to the specific diagnosis, the mental health diagnosis or provisional diagnosis or preventative diagnosis that EPSDT does allow. But it does have to tie back to those services, does have to be listed in those treatment plans. And so it doesn't allow one for unallowable Medicaid or unallowable activities through Medicaid reimbursement, same as our system through school-based health services. And it only allows what's listed and tied specifically to the diagnosis or the medical necessity that's there for those services. A couple things to remember in these ways of engaging, remembering that community partners, they may not have the same work hours and they may not have the same school year. And so they may be a 12-month employee, they could be a 10 or 11-month employee. They may have to work 8 hours, so they may have to start at 8 and end at 5 or whatever the time frames may be for that. So during those times, they may need access to students. If there's an after-school program or if there's a summer program, having access to those students so that then they don't end up building a caseload in the office and a caseload in the school. And so if we want them full-time, we have to make sure they get enough hours of services and get to stay in our offices and can provide maybe telehealth services from our office, but not feel like they have to leave at 3 o'clock if their workday actually ends at 4 or 5, or get as close to that as we possibly can, so that that person can feel like they can still fit into our system and our district, even if their schedule is different than what we're used to. Also, some providers will allow for an off-campus lunch hour. And so thinking more traditional and outpatient services, some of the staff that may come from community partner organizations may not quite fit into the culture as well and be used to eating lunch with the students and doing work while eating lunch, and they may want off-campus lunch hours. That can be something that can create a little bit of conflict, but maybe something to remember that they don't have the same requirements unless that community partner creates a policy or procedure around that. Next, sustainability is based on, just like sustainability with school-based health center or school-based health services, it's based on reimbursement of Medicaid allowable services. And so that being the case, those individuals do have to document services in their electronic health record system. Oftentimes organizations require that has to happen within 24 to 72 hours. and that they need enough one-on-one or group service time with students with Medicaid that have a diagnosis and a completed assessment and treatment plan for 4 to 5 hours a day. And so that's filling 4 to 5 full hours of services. Now, that could be 20 minutes a piece, or that could be 30 minutes a piece for each one of the interactions with students, but it needs to equal 4 or 5 full hours so that they're able to get enough Medicaid reimbursable activities to be able to sustain their role, their salary, their benefits, et cetera. And different from the way that schools may fund some of this, oftentimes there's not other funding mechanisms outside of Medicaid. And so with those rates that are there, there's not some other like local taxes or local resources or other ways to fund this outside of Medicaid and commercial insurance reimbursement. Speaking of commercial reimbursement, those community partners have to make families aware that there are copays, deductibles, coinsurance, and families are aware of their commercial insurance benefits, but they have to make them aware that they will be charged for those things. And in fact, they cannot not charge it. It is considered, if you don't charge commercial insurance or don't charge one group, but you charge another, like if you do the full fee for Medicaid or Medicare, it's actually considered Medicare or Medicaid fraud if we are not charging fees for one insurance, but we do charge fees for Medicare and Medicaid. And so it is a requirement by law to do this unless all services are being provided at no cost to any insurance company. And so those copays, those deductibles have to be there. And as I mentioned before, Medicaid will actually reject a claim if there's commercial insurance, and there's a database at the state level that actually many times will know what commercial insurance students are in. And so if it hasn't gone through the commercial insurance, a claim hasn't been submitted there first and then rejected, or a portion of that covered, then Medicaid will not cover that service either. And so when we're looking at that 4 to 5 full hours providing services, we want to be able to make sure those are actually reimbursable hours that aren't being provided and then not reimbursed. And so this is how we can sustain community partner implementation within our school district. Now, sometimes grants or contracts can cover the out-of-pocket cost for families, or districts might cover that sometimes. And then the other thing that districts many times will do is only have the community partner provide services to students that have Medicaid, and then use other providers within the school for those who have commercial insurance, or encourage referrals to outpatient settings for those who have commercial insurance. And so there can be different ways of kind of targeting who is it we're trying to reach, and it will influence Medicaid, the amount of Medicaid reimbursement, or the percentage of the activities that end up being Medicaid reimbursable through that. But ultimately, whether we're partnering with a community organization, whether we're expanding our mental health services within our district, whether we're using partnerships within the district and multiple service types and providers, we are all working towards the same thing, and that is the mental wellness and mental health of all of our students. And so how do we partner together and create the right partnerships and provide the right amount of resources and supports that address and meet the needs of our students? That's ultimately our goal across the board. That's what this entire 5-part series was about. And this series is hopefully helping the district identify partnerships or resources or strategies and tools for enhancing Medicaid reimbursement and obtaining Medicaid reimbursement if you don't currently have that, but maximizing it as much as you possibly can using our new state plan amendment and what is allowable under Medicaid for school health services and community partnership services so that we can make sure our students' needs are being met and that we become a healthier Illinois together.